to do events like this. And our topic for today's event is understanding chronic lymphocytic leukemia treatment sequencing. This topic was chosen because frequently those living with CLL will face multiple therapies throughout their lives, and having so many options is fantastic, but can make it a little bit confusing. So it is our hope that this event can help clear things up a little for you. Our first presentation will be a CLL 101. This will be with Dr. Nicole Lamanna. And Dr. Nicole Lamanna is an associate clinical professor of medicine in the hematologic malignancy section at Herbert Irving Comprehensive Cancer Center at Columbia University. Dr. Lamanna is a hematologist oncologist whose research interests include lymphoid leukemias and specifically chronic lymphocytic leukemia. She is an experienced clinical investigator, and her research focus has been the development of combination therapies that include chemoimmunotherapies, immunomodulatory drugs, novel kinase inhibitors, monoclonal antibodies, and many more. She is working to find active, safer therapies for older patients with these diseases. And we are so honored to have you here today, Dr. Lamanna.
Hi, how are you? God, that's old. I have to
Wonderful.
redo that.
You look the same.
Yeah,
I
right.
I think so. But thank you again for joining us today.
Absolutely. Let me try to share my screen.
Okay.
Let's see. Don't you tell me if this is, let's see, display. Is that good?
That's perfect.
Excellent. Okay. So for the, I have the easy job. My colleagues have the hard job. And so I am so grateful to have them, to have some expert folks with me today. I'm really going to do the basics and talk a little bit just about diagnosis. And depending upon where all of you are on your journey, some of this you already know, maybe a lot of this information, but for some of you where this might be a new diagnosis, perhaps some of this is all new. So forgive me if some of this seems much more background, and I'll try to go through this really quickly because my colleagues are going to really talk about frontline therapy and relapse therapy, meaning when you need treatment again for your CLL. And as Dalton had mentioned, this is a chronic disease, so many people may need more than one treatment. I work with everybody, so here's my disclosures for any, both for research and for advice. We partner with lots of different companies to find newer drugs and hopefully a cure one day. And certainly they support our research at the institutions that we're all a part of. So this is a little bit of background. When we think about blood cancers in general, they far are more rare diseases than when you hear about like breast cancer and lung cancer and colon cancer. CLL is the most prevalent of all the leukemias, but certainly it is still a rare disease when you think about all the blood cancers combined and pooled together. But because the fact is that it is a chronic disease compared to some other leukemias, it by far is the most prevalent leukemia because many people live very long lives. And thankfully, the median survival of CLL continues to improve. So we still have, when I first started this disease, it was under 10 years. Forgive my background since I'm at the hospital. lots of noises going on. But certainly the median far exceeds now over 10 years and continues to improve. So that's the good news. It is a disease of older individuals, so keep that in mind. You could see that it increases by decade. And so it is, although lots of us who do CLL do see younger patients, it typically is a disease of older individuals. As I mentioned before, it is a blood cancer. And I want you guys to think about this differently than when you think about solid tumor malignancies. People always ask, well, where is this? Well, typically it generates in the blood system. So when we think about the bone marrow, I want you guys to think about the bone marrow as a compartment. Think of it as the machinery or the factory that makes all your blood elements. And so it generates in the bone marrow and then goes out into the blood system. Your lymph nodes are also part of that hematopoietic blood system. So think about those cells are in the lymph nodes as well, or can be in the lymph nodes as well. And so that's part of the blood system. The blood system runs everywhere in your body. So when people go, well, is this in my liver or is this in my toe? It is if I'm going to pick up blood cells if I do a biopsy. So I want you to think of that, which is very different than when you think about, breast cancer or lung cancer, where there's a mass, they want to remove it. They hope it hasn't spread anywhere else outside of that area, right? So it has a different connotation when you talk about solid tumor malignancies and solid tumor cancers than when you talk about this cancer. So just keep that in mind. You know, people sometimes you might be called SLL or small lymphocytic lymphoma. Some of you might go by CLL or chronic lymphocytic leukemia. I want you to know that that is a distinction really based on where the disease is more present in your body. So if you have more lymphadenopathy based disease, your doctor might say that you have SLL. If you really have bone marrow or blood counts, bone marrow and blood count involvement and lymph nodes, they might call you CLL. It is the same disease. Do not get confused. I think, unfortunately, that we confuse patients. So please don't. It is the same disease when we look at the cells under the microscope, and it is treated in the same fashion. So it's just where the bulk of your disease is. And so just keep that in mind. People always ask, how do I get this? How did I get this? You know, in general, unfortunately, we don't know that you know, most individuals, unfortunately, we don't have a cause or an etiology. However, like many cancers, you know, they're obviously large environmental exposures or things that could contribute to the development of CLL or SLL. So, you know, think about Agent Orange or, you know, toxic chemical exposures, 9/11, you know, here in New York, I'm in New York. So those who are in the area of 9/11, you know, obviously there's an high incidence of lots of different cancers due to that. Chernobyl. So think of major environmental exposures where people can develop cancers due to those toxins. Now, people ask, is this genetic? Is this something that runs in my family? Now, it is true that if you have other family members who might have CLL, that there might truly be a familial incidence of CLL in the family, but that is not common. So that is a rare, you know, it is not very common at all, you know, and so it typically is not something we would normally say you need screening for that. If you have a relative, we would say that as long as, since this is a disease of adulthood, as long as your children are, when they get to be adults, seeing a primary care and internist, that's probably more than they need. But we do think it's important to take a good cancer history screening because CLL or SLL could be a part of other there might be another genetic or familial mutation that runs in a family that could expose or predispose to many different cancers. And so, you know, you should be having, at least when you first meet your oncologist, a general a discussion of your cancer family history in case there does need to be a referral to genetic screening based on the incidence of lots of other cancers that may run in your family. So keep that in mind. But typically CLL is not a familial disorder. Now, what about how do people present? And most people really, this diagnosis is picked up incidentally, right? So they pick up on, maybe they saw their internist or primary care doctor and had blood work done. Maybe they felt a lymph node and went to see somebody, or maybe they got picked up because they were having screening for something else. Women who get mammography often get picked up on their mammogram with some lymph nodes, or somebody who might be having pre-surgical testing for a surgery, an elective surgery, might, you know, get with those blood counts, get picked up that way, or maybe on imaging picked up a small lymph node that way, and then they get sent for an evaluation. So most people don't present incidentally and didn't know they might have had this disorder. So there might be some lag time with that. People who do have symptoms, the symptoms could be varied. And so fatigue is a general symptom. Sometimes it could be really truly related to progressive disease. So if the blood counts are starting to change or the lymph nodes are starting to grow, people can certainly feel fatigued that way. There might be even people who really don't need treatment, but have a level of fatigue that we can't really, you know, earmark or quantitate, unfortunately. And that's one of the things that it can be troubling a little bit about this diagnosis is sometimes people may have some symptoms, but yet we don't really recommend they need treatment. And those are harder things to sift through, of course. Shortness of breath can develop for people who possibly, if they if they become more anemic, that i.e. their red count is low, you know, they may huff and puff when they're doing activities because they have less gas in the car. I like to say the red cells are like your gas in the car. You don't have enough oxygen to the lungs. And so you might feel a little bit more dyspneic when climbing a flight of stairs or doing some exercise. And that can sometimes happen when people progress. Big and bulky lymph nodes, they shouldn't typically, they're not usually painful. Usually painful signals something acute is going on. Maybe they have an infection, a sore throat, that a lymph node swells up and they feel that their lymph node is sore, or you can feel the presence of your lymph nodes. Pain, you know, sometimes connotates a different thing, and you always should bring that up with your team. A big spleen is your organ is that can take up space in the abdomen, and so people can lose weight or sometimes feel uncomfortable with that. Infections are common with CLL patients, and we're going to talk a little bit about that later, but upper respiratory sinus and infections in the lung, bronchitis, pneumonia, are very common infections in CLL patients. Weight loss is concerning, I think, for anybody with if there's not unintentional weight loss that really should be brought to the attention of your team. Sometimes that could be due to progressive disease, but it can also have a connotation about whether or not has the disease transformed to a more aggressive lymphoma. So weight loss would certainly signal a discussion with your provider. And then night sweats, some people can feel that they drench their clothes, more at night as the disease is progressing. And if the platelets are low, those are the things that help us with clotting and bleeding. So if you have more bruising and bleeding, that might be a concern of progressive disease. What about when you first get diagnosed, though? How do we work this up? Well, the good news is most of this is done on your blood. So we can send, our testing has gotten so sophisticated that we can send testing off the blood. The testing to diagnose somebody is called a flow cytometry test. And essentially the pathologist can look at the proteins on your B cells and figure out, are these normal B cells or abnormal B cells? And if they're abnormal B cells, do they have proteins that are consistent with a diagnosis of CLL? Because there absolutely are other, believe it or not, other B cell disorders, lymphomas and leukemias that also need to be ruled out as well. So that's how we confirm the diagnosis. And then there's a bunch of testing that we do to try to learn about your CLL or SLL more compared to someone else. So there are prognostic markers or markers on your CLL cells that might tell us a little bit about your disease, as I said, compared to someone else. And so some of these are called cytogenetics or FISH analysis or fluorescent in situ hybridization. And it's a test that looks at chromosomal abnormalities, not that you were born with, but that are on your CLL cells. And we do a hierarchy of some may be considered what we think are favorable chromosomal abnormalities to have, and some may be less favorable. And so again, it tells us more about your disease. And then a lot of you have heard about this test called the immunoglobulin heavy chain gene rearrangement or mutational testing that looks at whether you are mutated or unmutated, and you're usually one or the other. And again, this tells us a little bit more about how your B cells are in terms of maturity and whether or not if you're mutated or unmutated, one is considered more favorable, one is considered less favorable. And again, these are just tests to kind of give us a little more sense about your biology of your disease versus somebody else. And then there's a slew of other blood tests of beta-2 microglobulin and even others that we will do that, again, give us a little bit more information prognostically about your disease versus someone else. And these are things that normally we do at baseline testing. So when you first get diagnosed. However, some physicians wait to do these later on and do that prior to somebody needing treatment. And I think, as long as these are done, because it may have in particular some relevance regards to treatment, although that may change over time, it's important to do these baseline tests so we can tell you a little bit more information about your disease. People always ask about the dreaded and fear procedure of a bone marrow aspirate and biopsy. Most patients don't need this during initial workup, and many may not need it depending upon how our future of sort of detecting diseases in the blood. I still think bone marrow evaluations may be of value, particularly, let's say, if for some reason the blood or is not confirmatory about your diagnosis, or there's a concern that you might not have CLL versus a different disorder, or if there are maybe some cytopenia, meaning if the counts are low and there might be an autoimmune issue that the doctor might be wanting to assess whether or not they're going to add particular therapies to treat your disease. So sometimes a bone marrow and aspirate and biopsy could be very valuable. And so I don't want to poo-poo it or say that it may not be done on it certainly isn't done on many patients, particularly at diagnosis, but it might be necessary later on, depending upon the indications with your physician. Now, people always ask me about the role of imaging. And so CT scanning is not something that needs to be done routinely. I do think that, CT scans are important for CLL and SLL patients, particularly maybe as a baseline study prior to starting treatment, or for sure, if somebody's having a complaint or a symptom about something. We often will do, so CT scans will show you the size of your lymph nodes, and it will look at your organs. A PET scan is something different. A PET scan is a test that looks at how the avidity or uptake of these lymph nodes. And so the radiologist will read these in degrees of uptake. It's a black and white picture that's superimposed on the CAT scan. So it'll look at the lymph nodes and where they are, and then they have a black and white feature that will go on top. And so lymph nodes with what they call high uptake might be important to biopsy if we're concerned that the CLL might be changing to a more aggressive lymphoma. And so we'll only do a PET scan if we think that there's some other concern about their disease that maybe we need to look for that possibility. And that's where a PET scan can be helpful. Otherwise, me just feeling the lymph nodes that are going on externally are usually about the same size as the lymph nodes that are going on internally. And so physical exam and blood counts are usually what is mostly needed. But again, somebody has a complaint, or if there's some really big and bulky lymph nodes and you want to see if those are big and bulky on the inside and causing compression on an order, that's, prudent CAT scanning is important. And you often use in, as I said, prior to starting some therapy. But just to do CAT scan images every 6 months or a year, just to follow somebody's lymph node that goes from 1 to 2 centimeters, if we're not going to treat them, I don't think that routine imaging all the time is necessary on CLL patients. Okay. Now, we do have staging system, but I just want to say briefly that the staging system in CLL is really just to help docs that when they first meet an individual, they're looking at, what are their blood counts and their lymphocyte count, but more importantly, what is the burden of their disease? Do they have big and bulky lymph nodes? Are their blood counts already low? And what this staging system then tells the doc is that, if they have more advanced stage, it means that they're likely going to need treatment sooner in the near future. And that's where staging comes into play. Otherwise, it's not the same staging system when you think again about solid tumor cancers and a mass that has grown outside of the lung or the breast and then is in another organ. That's stage 4 and has very different implications. This is not the same thing whatsoever. And I want to stress that to patients so that they don't get scared, that again, it just kind of tells the doctor, if this is when you're first diagnosed and your red cell count is low and your platelets are low, the likelihood is you're going to need treatment in the near future. And they use that. And that's how these guidelines help them. There is actually an indicator that physicians can do online that also will tell them a little bit about when they need treatment and also about their survival. And so this is what they call the CLL International Prognostic Indicator. There are many of these with different iterations of which factors they put in. Then again, is something that the doctor can use as a tool if they need to. But really what the doctors do in theory, indirectly, is they look at when somebody might need treatment. As I said, patients are not treated unless they need treatment. And these are some general guidelines about active disease when somebody needs treatment according to the International Working Group in CLL. And so if their good counts are starting to decline, if their red cell count is starting to decline, that means the term anemia that you guys might hear often, or their platelets are starting to decline, and that's thrombocytopenia, that's when somebody might need treatment sooner. If they have big and bulky lymph nodes or a big and bulky spleen that's causing them to lose weight, that would be another reason to treat somebody. And then patients are always focused on the white cell count, and it's not the absolute number or white cell count that is used to say if somebody's got a white count of 100, I'm treating them. It's really the rate of change of the white count. So if somebody's white count is rapidly increasing and going from 20 to 40 to 80 very quickly in a short period of time, those are the patients I'm seeing more frequently in the clinic. And that's how I use the white count. It's a guide. It's to tell us that, whether or not what's going on in the bone marrow, if the white count's rising quickly. And that means I'm just changing my appointment. So I'm seeing the patient more often, because it's my goal to sort of catch the patient before they really start having symptoms of their anemia or their platelets dropping, so that I can say it's time for treatment. And so that's how we use the white count. There are some patients that truly do have masses or nodal compartment of their disease. That's not so common, but it can happen. And that would be another indication of treatment in the kidney or the lung or skin, for example. And then CLL is a disorder of your immune system. So there's lots of other autoimmune processes where your body can attack itself in a different way. It is from the CLL that's underpinning this, but it's a different mechanism. So let's say somebody develops autoimmune hemolytic anemia or autoimmune thrombocytopenia. The bone marrow is making those cells fine, but when they leave the bone marrow and go out into the circulation, something has triggered the body to attack maybe the red cells or the platelets. And sometimes we'll use different treatments for those diseases or entities in a CLL patient. Sometimes it happens when patients are rapidly progressing too, and then we might offer full treatment for their disease. But sometimes it may happen because it could be triggered by something else, and they might just need a course of steroids or a monoclonal antibody. So there are some other reasons to treat CLL. And then constitutional symptoms such as fatigue and night sweats that we talked about earlier are usually in the face of progressive disease. How do we look at you guys? We look at you, when we talk about therapies, and again, my colleagues are going to talk about therapies, is really talking about they're going to talk about your comorbidities, what other medical problems that you have when we do considerations for treatment. And they do look at your prognostic markers and things that they might finesse your treatment accordingly, depending upon some of the markers you have. Although as the treatments get better, maybe this will be a mute conversation. And they'll also talk about your lifestyle, your supports, your goals of therapy, and so on and so forth. And again, they're going to cover this when they talk about treatment. I like to show this slide just to show you how far we've come. As somebody who started in the early 2000s treating CLL and have given chemoimmunotherapy, we've come a long way. And as I said, the survival keeps getting better. And so that's the good news. And my colleagues are going to talk about the therapies in more detail. But I want to talk about a little bit before we talk about therapy about what about you folks that are being actively monitored. This is a term that many of you say, watch and worry. I really want to replace this term. I can't stand it. Because there's a small group of folks who never need treatment, and I wish we could do a blood test on you and say you never need treatment and you can go on your merry. But then the folks that are really the majority of folks do need treatment at some point during their lifetime. And the reason why, to be in the active observation and monitoring group means you don't need treatment yet. And since there is currently no therapy that's curative, although I'll never say that I haven't had a patient who got chemoimmunotherapy back in the day with FCR, for example, and 20 years later, they're still in remission and probably maybe in a cure. Most people, that's not typical. So most people, we give therapy and their disease eventually comes back. And so as Dalton noticed and my colleagues are going to talk about, people might need more than one therapy during their lifetime. And so, we typically expect that. But if you're in the active observation and monitoring group, that means you don't need therapy yet. And remember, all therapies, even as good as these targeted therapies are, have some sort of side effects. And the therapies continue to evolve. So what may be applicable 10 years ago may not be applicable now. And that means you didn't have to get exposed to that therapy. So I think that, even though it's a challenge in your psychological challenge to be in the active observation and monitoring group, it has a lot of advantages because you don't have exposures, you don't have toxicities, therapies continue to evolve. And I think that's really, really an important thing to keep that in mind if you're in that group. And then briefly, just to introduce the names before they talk, the targeted therapies they're going to go over. And so they're going to go over the current therapies that we're using in CLL, monoclonal antibodies. So the targeted therapies are BTK inhibitors. So they're going to talk about those, BCL2 inhibitors, venetoclax. And we have PI3 kinase inhibitors as well that are still in the relapse setting if needed, and others. So those are more targeted therapies that the gang's going to talk about. And then monoclonal antibodies are either infusions or injections that target a protein on your CLL CD20. And so oftentimes they can be used in combination with some of these other agents. We've moved away from chemotherapy a lot. These are some of the names, and some of you might have received some of these therapies in the past. But these are drugs that traditionally really were effective in treating CLL, but also had a lot of other side effects associated with them, and often given in combination with obinutuzumab or rituximab, and that's when it was called chemoimmunotherapy. We have our first CAR T-cell approval, and I'm sure Deb's going to talk about that. And then we could always talk about transplant, although that has not certainly has been used less often because of all the treatment options that we have for CLL. And then, of course, clinical trials, stuff that we're all involved in that have moved the field forward and have brought patients all these new agents that are now part of standard of care. What does a targeted therapy mean? Just to sum up, it's a cancer treatment that may affect a particular area, a protein or receptor or pathway in CLL cells and their development. They try to really not target healthy cells, which is what chemotherapy did back in the day. So there are less side effects of some of these targeted therapy, but they really try to block or turn off signals that prevent the cancer cell from growing, or maybe they change some of the proteins. So depending upon the targeted therapy, they may impact the cancer cells in a much more targeted fashion than what we did with chemotherapy back in the day. And so their different targeted therapies do different things. And again, the gang will show that. We'll tell you about that. These are some of the targeted therapies that are approved, and they're going to talk about the BTK inhibitors and the non-covalent BTK inhibitors. They'll talk about PCL2, and they might touch a little bit about PI3 and CAR T. And just to finish, CLL is a disorder of your immune system. And so even though we focus a lot about targeting the B cell and trying to eradicate the CLL cells, it does have a lot of impact on the cells that support the CLL cells. And so there's lots of different issues that you as a community and the journey of your CLL go through. We talk about infections a lot and some of the impaired immunity of patients with CLL. We talk about autoimmune issues, the ones I talked about from the blood, but also people can get other immune mediated issues in their skin and others. So CLL has a lot of impact, not just of the CLL cell itself, but a lot of impact on other of your bodily immune systems that can be relevant for some of you along that journey. So with that, I want to say that it's important, and we tell all of our patients that, because of your immune system and the impact to other systems, it's really important to make sure you're getting your routine healthcare maintenance, seeing your physicians who take care of your other problems, and that we know that you guys have a higher incidence of other cancers. So it's important to screen for other cancers because other cancers are potentially curative, right? So if they find a squamous or a basal cell, they remove it. So please do your annual dermatology screening. It's probably the most common cancer we see in CLL, but also your other cancer screening, that's important. And as I said, infections are really probably one of the most common causes of morbidity and mortality that we see in CLL patients. So we do recommend that you have a good relationship, whether that be your oncologist who deals with your infections or your primary care or internist who deals with your infection. Have a go-to that you can call for somebody if you're getting sick so they can tell you what you need to do or help you get better. We do recommend routine vaccinations in our patients. And again, we think of the vaccines as a way that we hope that your body will recognize whatever that vaccine is covering, whether that be flu or something else, so that then when you get exposed, your body will go, oh, I kind of recognize that. I am going to try to fight this off or diminish the severity of that illness. And that's what vaccines are supposed to do. Now, we know that CLL patients don't mount the best immune responses to vaccines. But if there's anything that might help you from getting really sick, we're going to try to say this is in a way a preventative or prophylactic to just try to help you all get through these most common illnesses that we all deal with. So think about that. We don't recommend live vaccines currently, just because theoretically you might reactivate that virus. But there may be considerations depending upon what that illness is. And then there is some things that we can boost people's immune system, the use of what they call gamma globulin or intravenous IVIG. In some patients, we might offer that to help if they have a lot of infectious complications, but there are ongoing clinical trials to try to assess how important this treatment is, or how can we use this treatment to help our CLL patients do better. So stay tuned. With that, I could go on forever. I will shut up so that my colleagues can take over and talk about the therapies in particular.
Great. That was super good. I think that was a perfect setup for the rest of the presentation. I did just want to let everyone know, if you're interested in learning more about how CLL affects your immune system, we did do a webinar back in February with Dr. Andres Chang, and I think that event went really well, and he covered quite a bit of that topic. So that would be a good one to check out. And I am also in the works to do a CLL and secondary cancers event that's likely to be next month. So if those are topics of interest to you, we've got those out there as well. But now moving on to our next speaker, this is going to be all about first line therapies. And joining us for this presentation is Dr. Bita Fakhri. Dr. Fakhri is an assistant professor of medicine in the Division of Hematology at Stanford University School of Medicine. She specializes in the treatment of chronic lymphocytic leukemia, or small lymphocytic leukemia, or small lymphocytic lymphoma, as we just heard. CLL and SLL are the same, as well as hairy cell leukemia and other hematologic malignancies. As a clinical scientist, Dr. Fakhri is dedicated to caring for patients, teaching trainees, and researching novel therapies for patients with CLL or SLL. Dr. Fakhri has co-authored numerous publications on topics including CLL, novel targeted agents, and cellular therapies for patients with hematologic malignancies. And with that, I'm going to turn it over to you, Dr. Fakhri.
Thank you so much. It's great to be here. And Dr. Lamanna, that was a very effective summary of all the questions that I get asked about when someone is just diagnosed with CLL and things start clicking. So thank you for doing that so masterfully in 20 minutes. So I will be talking about considerations for treatment of treatment-naive CLL. And just to start, we don't necessarily say patients with a new diagnosis of CLL, because you heard that there are a good number of patients with CLL who are under watch and wait approach for quite some time. And unlike a lot of malignancies, new diagnosis does not necessarily require treatment right away. So treatment naive patients are patients who meet the criteria for initiation of therapy, which you just heard. And now we are considering different treatment options for these patients. These are my disclosures. I also work with everyone, and here is for
You're
you.
not sharing your screen yet, so.
It says share screen, and I am sharing your screen sharing.
Wait, there we go.
Okay.
Let's try that again.
Okay, sorry about that.
It might have been on my end. Because I think I may have just not had it selected. So that's probably on me.
Okay, let me share again. Sorry, now it just kicked me out.
Oh, sorry about that.
Okay, can you guys see what I'm sharing?
Yes, now we can.
Okay, perfect. So that's where the term treatment naive comes from, my disclosures for you to see. And then key factors in managing patients with CLL. So you heard about timing of therapy. I'm not going to go through that. There is a group called International Workshop on CLL that gets together every 2 years and has introduced criteria for initiation of therapy, which Dr. Lamanna very eloquently mentioned. And then in choosing treatment options, there are key prognostic factors that go into play. One of them you heard about FISH, the chromosome analysis. In the era of targeted agents, 11q deletion is less of an issue, but unfortunately, patients with TP53 aberrant disease, those are patients with 17p deletion and TP53 mutation, who are still having a less favorable prognosis and are a huge consideration in designing clinical trials and also choosing the right treatment option. And you also learned about IGHV mutation status and why mutated IGHV speaks to a better prognosis. And it's kind of counterintuitive because when you have mutated, it's just like the proliferation of your CLL cell was halted at a later stage. So you're dealing with more differentiated, more mature CLL cells. And like adults, these cells are expected to behave better. And then there are other exercises in the field like MRD analysis to guide clinical decision-making. But I do want to emphasize that in 2025, MRD-guided duration of therapy is still an intellectual exercise. We do it in the clinical trials, but should not guide duration of therapy outside clinical trials for patients who are not participating in a clinical trial. And then talking about classes of agents, you did hear about Bruton tyrosine kinase inhibitors. BTK is an enzyme that is involved in proliferation, survival, and differentiation of CLL cells. So by inhibiting this enzyme, it's like putting your foot on the brake pedal. As long as your foot is on the brake pedal, the car will stop going. But when you remove it, the car will start going again. That's why the rationale behind indefinite therapy with BTK inhibitors is because you need to inhibit the enzyme constantly. And then we have BCL2 inhibitors. Venetoclax is currently the only BCL2 inhibitor that is FDA approved. And it's basically in our language, it's a pro-apoptotic agent, meaning it goes and asks the CLL cell to go and kill itself. That's why the idea of a deep molecular remission to a level that can potentially give us opportunity for time-limited therapy was introduced by BCL2 inhibitors, because they can kill the CLL cell to a deep level that patients can enjoy treatment-free remissions. And then anti-CD20 monoclonal antibodies. CD20 is an immune marker that is expressed on the surface of CLL cells. Rituximab was the first one. And then obinutuzumab is a more recent one that we're using combined with other targeted agents. And you also heard about chemoimmunotherapy, fludarabine, cyclophosphamide, rituximab, and bendamustine rituximab, which we are not currently using in the United States, and also chlorambucil, which is an old alkylator, but it used to, I wouldn't be surprised that some of you in the audience have received some of these agents. So now to move on, this is a pretty busy slide, but this tells the story of CLL in the past 11 years. And I'm just going to go through it like storytelling, and then we'll go through some of the details of each of these clinical trials. So I'm going to drive from basically top left. As we're sitting here in April 2025, the first targeted agent for CLL, ibrutinib, was approved in February of 2014. And that was basically for relapse refractory patients based on the RESONATE-1 clinical trial. We give our clinical trials names. So RESONATE-2, based on the success of ibrutinib, which was the first covalent BTK inhibitor that was introduced to the field, the next rational step is to take ibrutinib, which was successful in the relapse refractory setting, to the frontline setting. And then they compared ibrutinib to chlorambucil, which was an agent that was used at that time. And here you see the basically yellow line. These are what we call Kaplan-Meier curves. And the translation is there are two lines or two arms of the study. The yellow arm indicates patients who have received ibrutinib, and the blue arm is the patients who have received basically chlorambucil. And progression-free survival is a fancy term that we use indicating which arm of the study had a longer basically remission period. Let's put it that way. And here you see that the winner arm was the yellow arm, which was ibrutinib. So given the success of the RESONATE-2 trial, the next question in the field was, okay, now that we have this targeted agent that is working really well against chlorambucil, let's examine it against some real deal. And this is at the time that a lot of patients with CLL, real deal was chemoimmunotherapy. So if we have confidence in this molecule, let's compare it to the real deal. And that's where the Alliance and ECOG groups, there are two groups composed of different academic institutions that try to answer unmet needs in the field of CLL and other malignancies. So the Alliance group compared ibrutinib versus ibrutinib plus rituximab, the CD20 monoclonal antibody, versus bendamustine rituximab, BR, or bendamustine rituximab was a chemoimmunotherapy that was approved for patients, older patients with CLL, because it was better tolerated compared to the other chemotherapy, which is FCR. And here you see the top two arms are ibrutinib arms. Whether it was single agent ibrutinib, you really can't tell. They really are the mirror image of each other, or ibrutinib plus rituximab. But there is a huge gap between ibrutinib containing arms and bendamustine rituximab. So based on the Alliance trial, and this is a landmark important trial, and also the ECOG, which examined the very same concept of ibrutinib, shown with the red line, as compared to FCR, a pretty heavy-duty chemotherapy regimen that we used to use for young patients with CLL. So the Alliance and ECOG groups showed that this new molecule, ibrutinib, the first covalent BTK inhibitor, was the winner against chemoimmunotherapy, whether it was bendamustine rituximab in older patients or FCR in younger patients. So that's when the field of CLL, at least in areas that have access to these targeted agents, left chemoimmunotherapy behind in favor of targeted agents. Then in 2014, the German CLL study group introduced a new topic. So CLL14, Germany has a very strong CLL group, and the way they name their studies, you see there are no fancy names. It's just CLL and the year that the idea of the trial was conceived. So CLL14 was basically an effort to introduce time-limited therapy to the field. And we learned from Alliance and ECOG, yes, ibrutinib was the winner, but it is indefinite therapy. It should be continued until disease progression or intolerance. CLL14 was 1 year of combining venetoclax, which is a BCL2 inhibitor, plus roughly 6 cycles of obinutuzumab CD20 monoclonal antibody, and compare it to the old regimen of chlorambucil plus obinutuzumab. And here you see that the 6-year follow-up, the 6-year progression-free survival of the CLL14 trial is 53%, meaning in patients who took the combination for 1 year, enjoyed a treatment-free remission, no medicines for their CLL for 5 years. At 6 years, 5.3 out of 10 of those patients are still enjoying a remission. CLL14 is another very important trial in frontline setting because it introduced the idea of time-limited therapy to patients with CLL. And then as we started using ibrutinib more and more often, we realized that ibrutinib is associated with toxicities. Great molecule, transformed the field of CLL and a number of other B-cell, basically lymphoproliferative disorders, but was associated with an unfavorable cardiovascular side effect profile, particularly when it came to atrial fibrillation and some basically ventricular arrhythmias/dysrhythmias, long-term hypertension. And, the expectations go higher and higher. If someone didn't have any option and got ibrutinib and went into remission, they were so happy at that time. But then, the joint pains came on, the muscle pains came on. People did not want to take 2-3 other antihypertensives or blood pressure medications to control their blood pressure. So the expectations go higher and higher. People are like, now my cancer is in remission. I want to run a marathon and my joint pains are basically a limiting factor. So that's when newer generation BTK inhibitors were introduced to the field. So Elevate treatment naive was a combination of, was 3 arms actually. One of them was a combination of acalabrutinib plus obinutuzumab that we'll talk about versus single agent acalabrutinib versus coramituzumab obinutuzumab. And you see that both acalabrutinib containing arms were the winner. So based on the Elevate-TN, it was the registration trial for acalabrutinib in the frontline setting for patients with treatment-naive CLL. And then Sequoia trial was another trial that compared zanubrutinib, another new generation covalent BTK inhibitor, versus the old chemotherapy of bendamustine rituximab. And here you see zanu being shown in red as compared to purple. Bendamustine rituximab, again, was the winner arm. So ibrutinib came to the market, left chemoimmunotherapy behind. CLL14 trial introduced the idea of time-limited therapy. And given the toxicities of ibrutinib, the field felt the need to come up with better tolerated new generation BTK inhibitors. And that's how acalabrutinib and zanubrutinib got approved for patients with CLL. And just to go into details, here we did talk about the ECOG 1912 trial, just demystifying some of these regimens in more depth. This was ibrutinib versus chemoimmunotherapy in younger patients. We talked about CLL14, and here you see that the 6-year progression-free survivals with ibrutinib was 53%. With obinutuzumab venetoclax was 53%. There is some concern that venetoclax obinutuzumab time-limited therapy might not be the right treatment option for patients with high-risk features. It's important to know that when they did the sub-cohort analysis for patients with unmutated IGHV, who were 60% of the participants of CLL14 trial, the median progression-free survival was 65 months, meaning patients took the combination for 1 year, enjoyed a 4-year progression-free survival, and then their disease relapsed. So in my opinion, after discussing these results with my patients, time-limited therapy is still a very valid option for patients with high-risk features, particularly unmutated IGHV. The median remission for TP53 aberrant patients was 52 months, meaning roughly 3 years of treatment-free remission. And, it depends on what kind of doctor are you. Is that a patient are you? Are you comfortable with this data, or you think, you want something better? I do believe the field needs to do better, but, for some people, 3 years not being on treatment makes sense. And this is what I'm showing by TP53 status and also IGHV status and those data that I presented. In general, well-tolerated combination. Cytopenias are major, and we have learned a way to basically manage cytopenias. And when you are basically considering factors in choosing a BTK inhibitor versus venetoclax obinutuzumab, it is very important. I always tell my patients there is no right or wrong option. It really depends on what you want from your treatment. So BTK inhibitors, there is an element of convenience. There are no infusions. We don't monitor patients when we are doing the venetoclax ramp up for tumor lysis syndrome. But, do you want to be myopic or you want to have a long-term vision? Yeah, it's going to be a rough 2 months with venetoclax or obinutuzumab. Lots of labs, IV fluids, supportive care. But, if having treatment-free remission is something meaningful to you, then, you shouldn't let the initial convenience of a BTK inhibitor basically take the option away from you. And the other thing is with BTK inhibitors, it is treatment to progression, which is okay for some people. Taking a pill for the rest of their lives is totally fine. And again, it's a personal choice. BTK inhibitors have been around for now almost, 1.5 decades. So there is a lot of long-term efficacy data with them. And, with venetoclax or obinutuzumab, there is a risk of TLS, but the way we administer it by starting with obinutuzumab, debulking the disease, and then introducing venetoclax, the risk of tumor lysis syndrome goes down. And here, we talked about different BTK inhibitors. I talked about the Elevate-TN trial, which was acalabrutinib plus obinutuzumab versus acalabrutinib versus chlorambucil obinutuzumab, and how acalabrutinib was the winner. Again, acalabrutinib has a better side effect profile as compared to obinutuzumab. We did talk about the Sequoia trial, which was zanubrutinib versus bendamustine rituximab, and how Zanu was the winner. And in terms of side effect profile, zanubrutinib and acalabrutinib have never been compared in a head-to-head fashion, but both of them are very tolerable options for patients with CLL. And now the newest thing that you will probably hear a lot is a combination of a covalent BTK inhibitor and BCL2 inhibitor in the frontline setting. There have been a lot of efforts, the Captivate trial, the European GLOW trial, the UK FLAIR study that examined this concept of combining a covalent BTK inhibitor and a BCL2 inhibitor. Amplify was a major effort, basically randomizing patients with treatment-naive CLL to either receive a doublet. The covalent BTK inhibitor partner was acalabrutinib combined with venetoclax, or triplet, BTK inhibitor, BCL2 inhibitor, and a CD20 monoclonal antibody versus chemoimmunotherapy. And because they allowed patients to get randomized to chemoimmunotherapy, it was not ethical to include patients with TP53 aberrant disease, because by this point, we knew that those are patients who do poorly by chemo. If anything, chemo enriches the bad features, so their disease will come back sooner and more aggressively. And here you see that when we are talking about progression-free survival, despite the fact that the triplet therapy was had slightly better numbers, the 3-year progression-free survival was 83% with triplet versus 76% with AV versus 66%. But when you look at the overall survival, the doublet group actually did better. And when you look at the mortality, so I just put all 3 arms here, the 3-year remission with AV was 76% versus 83% when adding obinutuzumab. The overall response rate was almost similar, 93%. The reason that the mortality was worse in the triplet was mostly due to COVID-19 deaths, with the caveat that the trial enrolled very aggressively at the peak of COVID, before the vaccines, before Paxlovid, before antibodies. So the triplet arm had 25 COVID deaths as compared to 10 deaths with the doublet arm. And we all know that obinutuzumab is a CD20 monoclonal antibody. It not only targets the CLL CD20 positive cells, but also healthy lymphocytes that are expressing CD20. So based on this trial, we all anticipate that the doublet therapy, acalabrutinib plus venetoclax, also gets approved in the frontline setting. So then there's some future directions. We did talk about acalabrutinib venetoclax being an option in addition to obinutuzumab venetoclax. But, acalabrutinib venetoclax is an all-oral option. Obinutuzumab venetoclax, great trial, has passed the test of time. But the question is, can an all-oral overcome the inconvenience of obinutuzumab infusion? And I think one of the most sophisticated trials that we are waiting to read out and answer this question in a scientific manner is the MAGIC trial. So MAGIC trial is 1 year of treatment with AV versus OV. And at the end of 1 year, all patients get tested for MRD, measurable residual disease, to see whether they have eradicated their CLL clone at the level of our assays being able to detect CLL. And then if they're MRD negative, both arms stop after 1 year. If they're MRD positive, both arms continue the oral part in AV, both AV and in OV, only the venetoclax for an additional year. So this trial will finally answer the question, which arm is going to result in more durable remission in patients who are starting with all oral versus OV. And also another trial, Celestial TN, is another important trial that is going to shape the frontline landscape in patients with CLL in the next 3 to 5 years. This trial has completed accrual, and this trial was also comparing obinutuzumab venetoclax, a great treatment option for patients with CLL, versus time-limited zanubrutinib, which is a covalent BTK inhibitor, like acalabrutinib, plus a new BCL2 inhibitor, sonrotoclax. And the field is anxiously waiting to hear the results of these two trials, which can potentially shape the treatment landscape for frontline setting in the next few years. And with that being said, I thank you for your attention.
Great. Thank you. That was a super good presentation, and I learned a lot. So next up, we have our second line and beyond therapies. This will be with Dr. Deborah Stephens. So Dr. Stephens is an associate professor of medicine and director of the Chronic Lymphocytic Leukemia and Richter's program at the University of North Carolina School of Medicine. She joined the medical profession and specifically blood cancer research because she likes to develop long-term relationships with patients and finds the science behind blood cancer to be fascinating. Her specific area of clinical interest is chronic lymphocytic leukemia, and she is passionate about making life better for patients, whether it be through access to new therapies, be it clinical trials, education of patients, and the development of new clinical trials that improve quality of life and eliminate complications of living with CLL. We are thrilled to have you with us today, Dr. Stephens, and I'm going to go ahead and turn it over to you.
Great. Thank you so much for the kind introduction. And I'm really excited to be here with you today to talk about treatments for CLL or SLL that are beyond the first treatment. And I do feel like Dr. Lamanna and Dr. Fakhri really set this up nicely, because you're going to notice that I'm going to talk about some of the same drugs, using them in different orders. There are so many clinical trials out there that I don't have time to cover every single one of them. So I tried to really give some basic concepts and some of the most, I think, exciting drugs that are in clinical trials right now. But hopefully that will leave us plenty of time to have some questions at the end of the presentation. So let me show you kind of the agenda for what I plan to talk about today. I first want to just briefly comment on the reasons to start a next treatment for CLL. I'll want to talk about second-line treatment, and then I'm going to talk about third-line treatment, and again, just highlight some of the newer therapies that are coming through in clinical trials. So I think this is really important. I wanted to cover and highlight some reasons to start next treatment for CLL. And these are some of the same reasons that Dr. Lamanna talked about at the beginning of the presentation. Really, you're going to want to treat CLL again if it becomes active again. So you kind of go into that observation period again after therapy, or perhaps you're still taking those BTK inhibitor therapies like acalabrutinib, zanubrutinib, or ibrutinib. You're kind of in a holding pattern again. And really, I don't recommend making changes unless there's some specific reason and some symptoms that come up. So again, this is active disease. So maybe you have anemia or a reduced red blood cell or hemoglobin count. Maybe you have low platelets that are less than 100. Maybe your spleen or lymph nodes are enlarged and are causing pain or discomfort. And then again, Dr. Lamanna highlighted some of these B-type symptoms, which include weight loss that's unplanned. It includes fevers without infection, night sweats that are drenching without an infection, or severe fatigue. And, everybody's just a little bit different. And so there might be some slight variations to this. But I wanted to highlight this because we have so many new therapies and so many new technologies and laboratory studies that we order. And I wanted to just reiterate that those are the reasons why we would decide to choose a different therapy, and not just because a specific number of white blood cells is reached. We don't have any sort of magic cutoff, like we don't wait to them to hit 100, because you'll find that some people have symptoms way earlier than that, and some people can go on and have very high white blood cells without symptoms. And so no specific white number is a requirement to start treatment. I know some of your doctors are probably doing more sophisticated testings, like perhaps looking to see if you have resistance mutations to any of these treatments. And at least at this point in time, if a resistance mutation is detected in your blood, but you don't have any evidence of clinical symptoms or any reason, I wouldn't recommend skipping to the next line of therapy yet. And then we touched just a little bit on minimal residual disease or measurable residual disease. And sometimes your doctors might be checking this and they might see a return of that. Like, let's say you went through the venetoclax and obinutuzumab treatment that Dr. Fakhri just mentioned, and you had no detectable residual disease at the end of therapy. However, then your doctor suddenly detects maybe a small amount of disease coming back. That doesn't mean that you need to jump right back into treatment. Again, we're still kind of waiting, observing, doing active observation, and waiting until any sort of symptoms or cytopenias would occur. So options for second treatment for CLL are very similar to the options for treatment in first-line CLL. And Dr. Fakhri covered those very nicely. I'm going to cover them again just very briefly. But before I talk about them, I think both of the prior docs have said something about this. Clinical trial is always a good option. And so when you're talking with your doctor, selecting a next line of therapy, make sure that you ask them if there might be a clinical trial that's available for you. So when I talk about these next line therapies, the most common one used again are similar to frontline therapy, and they include immunotherapy. And these are basically in the second line setting, we're looking at antibodies like CD20, most likely rituximab or obinutuzumab would be the one used for your CLL. And targeted therapies. Again, Dr. Fakhri covered these really nicely. The BTK inhibitors like ibrutinib, acalabrutinib, zanubrutinib, venetoclax, and there are a couple of other drugs, idelalisib, which is not commonly used anymore just because of side effect profile, and pirtobrutinib we're going to talk about more in the third line setting. But the goal of these therapies is not like the old-fashioned chemotherapy is to when the old-fashioned chemotherapy went in and killed a lot of your normal cells, the goal of these therapies is really to focus in and hit just the cancer cell. So again, Dr. Fakhri has covered these, but Bruton tyrosine kinase inhibitors, they really block the cancer's survival signals or the B cell receptor signaling pathway. I think of it as like taking the gas out of your car. Again, these are ibrutinib, acalabrutinib, and zanubrutinib, which are the drugs that are approved for all patients with CLL, first, second, third, or beyond. And pirtobrutinib, which is really approved for patients who have relapsed after 2 or more prior therapies, including one of these other BTK inhibitors and venetoclax. Of course, venetoclax again was covered, but this is my take on the mechanism of action. Basically, your cancer cells are going to express a lot of this protein called BCL2, and that makes them live longer. And so venetoclax just blocks that protein, and so it promotes the cancer cells to go ahead and die. And this is approved in combination with either rituximab or obinutuzumab in all lines of therapy for folks with CLL. So when you're looking at doing a second line therapy, here are some key information that you and your doctors are going to want to talk about and make sure that you are clear and have a good history. And so importantly, what was your first treatment? Another thing, why did you stop your first treatment? Was it because you had side effects, or did you have progression or worsening of your CLL? And if you had time-limited treatment, and so that was, a couple of the options that Dr. Fakhri had mentioned in frontline, which would be venetoclax and obinutuzumab, or maybe acalabrutinib, venetoclax, zanubrutinib, sonrotoclax, some of those time-limited, meaning we know we're going to give that treatment for a set amount of time, not like the BTK inhibitor therapies, which are given continuously. So if you had a time-limited treatment, how long has it been since you finished the last treatment? And again, just want to highlight, this is a great time to ask your doctor about any clinical trials that might be available. So I'm going to talk about it in the concept if you had a first-line therapy of chemoimmunotherapy like fludarabine, bendamustine, or a frontline therapy of BTK inhibitor, or the time-limited treatment of venetoclax and obinutuzumab. And so really when your first treatment was chemoimmunotherapy, and again, this is very simplified. And so, every patient is going to have some nuances to this. And so it's a really simplified explanation of kind of the things that we're thinking about when we're recommending next therapies. But if your first treatment was chemoimmunotherapy, you still have an option to use either a BTK inhibitor therapy or venetoclax paired with a CD20. It currently is approved to be used with rituximab, but obinutuzumab is also a really great option that is currently in clinical trials in the second-line setting. If your first line of treatment was a BTK inhibitor, so let's say you got ibrutinib as a frontline BTK inhibitor, we want to know, did you stop that because of side effects, or did you stop it because of progression? And if you stopped it because of side effects, you might want to consider an alternative BTK inhibitor. So let's say you were on ibrutinib and you stopped it because of joint aches or pains, something like that. You might want to consider using zanubrutinib or acalabrutinib in the second-line setting. But if you were on the drug and you had progression of CLL, most likely you're going to want to switch out to a different class of therapy, and that most likely is going to be some version of venetoclax plus a CD20 monoclonal antibody. So let's say your first treatment was venetoclax and obinutuzumab. Of course, maybe we want to go to the other class of drugs that are active, a BTK inhibitor. But if it has been over a year since therapy, and again, this number is really not exact, and there's still a lot of studies to understand how long is long enough. But I would say generally, if it's been more than a year since your last therapy, you might consider actually doing retreatment with venetoclax and obinutuzumab or rituximab. You might notice a couple of things in my diagram here when I'm talking about starting BTK inhibitor therapies. Most of the time, I'm talking about starting acalabrutinib or zanubrutinib, and that's just because of the side effect profiles that look favorable to in contrast to ibrutinib. However, there might be some patients that actually might really benefit from ibrutinib, and there's some investigation trying to figure out who the patients are that might benefit. And sometimes I think if patients had a lot of other kinds of cancers, for example, skin cancers that are recurrent, or other specific reasons, you might need to do ibrutinib instead of acalabrutinib or zanubrutinib. I also didn't put a box up here yet for like what happens if you got ibrutinib plus venetoclax in the frontline setting, or acalabrutinib plus venetoclax. But I think actually it's going to look a lot like this down here, because there is some data that if you got a BTK inhibitor and venetoclax in the frontline setting, you might be able to reuse either of those medications. And so again, this is very simplified version of how we're making decisions on second-line therapy. So what about after the second-line therapy, you need a third-line therapy, or longer. Maybe some of you have had multiple lines of therapy already. And again, this is a great place to ask your doctor if there's a clinical trial available, because I think it's really important, especially for folks as they get through further lines of therapy. So I like to think about mutations, and I mentioned, you want to know, like, let's say you had ibrutinib as a first line or a second line therapy, and basically the CLL got worse. So why doesn't it work? And most commonly, what happens is the spot on the CLL, the cancer cells, where the BTK inhibitor binds, which is called the C481 moiety, it just changes a little bit. So the BTK inhibitor doesn't really fit very well with it. So it doesn't really block the cancer signals very well. However, any of you who have experienced this, maybe you start to see a little bit of regression, like maybe a little bit of higher white blood cell count, a little bit of larger lymph nodes, you know that you should not just stop the medication, because there are likely still CLL cells that are responding to it, and you will see a pretty big flare of disease. And so, you know, if you're thinking your drug is not working anymore, please make sure you're checking in with your doctor and not stopping medication unless you have another plan in place. This particular mutation applies to ibrutinib, acalabrutinib, and zanubrutinib. And so that's why I said it's important to know if you had one of these drugs previously, if you had progressive disease while you were on it, likely switching to the next one is not going to make a difference. Where that is not different is a new drug. It's an oral pill called pirtobrutinib. It still works because it binds to a different spot on the CLL. This drug has been really effective, and it is currently approved for folks who have had 2 prior lines of therapy, including a BTK inhibitor and a venetoclax. Sometimes you're able to get those drugs what is called an off-label use, meaning it's possible you might be able to get it earlier if your doctor kind of works with your insurance company and arrange for that. I don't think you necessarily need to get it earlier, but if there's certain circumstances which might mean you need this drug earlier, you can do it. The initial clinical trials, highly successful, great response rate, even in people who are no longer responding to acalabrutinib, zanubrutinib, or ibrutinib. And the good thing about this drug is it really has pretty limited side effects, and it's an oral therapy. So this is an option for third-line therapy. The other thing I want to highlight is CAR T-cell therapy. And this is also approved in the third-line setting for patients with CLL, and that's after you've had a BTK inhibitor and a venetoclax-based therapy. The currently approved construct is one called liso-cel. So basically, the rough concept of CAR T-cell therapy is basically we want these CAR Ts to go in and recognize things that haven't been recognized on your cancer cells and tell the immune system to attack and kill the cancer cell. So what that logistically looks like for you as a patient is, you know, first your blood is collected, then the cells in the lab are separated out. There's a vector that says it basically tells the CAR what to attack. In the case of liso-cel, that's CD19. And then you're going to multiply those T cells in the lab. And then coming back to you, you get some chemotherapy, and then the CAR T cells are returned. So that looks like an infusion, like actually looks very much like a blood transfusion when it goes in. And so basically this concept is trying to activate your immune system, tell your immune system to go after and attack those CLL cells. Of course, probably not everyone is going to be a candidate for this. For one, it's only done at certain centers, although the number of centers has significantly increased over the last few years. But there are important side effects, and so you want to make sure that you're in good physical condition. You don't have any other medical conditions like risk of heart attack or anything, because it is pretty stressful on the body. We're really overactivating your immune system, and you can get things like that is called cytokine release, which basically means the immune system has been overactivated, or you could get some toxicity to the brain, which results in temporary confusion or other little neurologic symptoms. And so these have to be monitored by folks at a specialty center. And you know what's really nice about CAR T is if you are able to get into remission with it. Some people have really long-term remissions, and so you do this treatment and then you have a break. So, you know, we've been talking about sequencing all of these treatments, but it is possible, and it looks like so far about 20% of people get a really long response to CAR T, which is really exciting. And you might have heard of some of these patients because when the treatments first came out, there was really kind of big news stories about this, highlighting the patients and how successful these treatments were. the problem, as I mentioned, it's only 20% that gets these long remissions. And so there's another portion of patients that they're going to get a remission, but it's not going to be that long-term remission. And so, you still are dealing with the cost, the side effects, and everything of this treatment, and you just really haven't had a long remission. And so, you really have to weigh the risks and benefits of doing this kind of more aggressive therapy. There are certain patients that don't have any response to CAR T. And so there are many clinical trials that are ongoing right now trying to figure out how do we make the CAR Ts work better? How can we figure out who are those 20% of people that are going to have a great response? Is there some marker we can look for and say, hey, this person's going to have a great response. We should definitely do CAR T. So we just don't have all the information yet. But these are very promising and very exciting treatments. So I just want to highlight a couple of new treatments to watch. One is called a BTK degrader. And, we've been talking about BTK inhibitors. And so basically your body, the CLL cells, it makes this BTK protein. And then in a BTK inhibitor, it blocks the protein. But in this case, after the protein is already made, the BTK inhibitor goes in and eliminates the protein. And so, I kind of think of it as like setting the gas on fire, I guess. And so basically what's really nice is I mentioned the most common reason you get resistant to the BTK inhibitors is this mutation site binding. That doesn't matter for BTK degraders. And so there's a lot of really exciting clinical trials going on with these agents. They are all oral agents, and they're showing really promising response, even in people who have had many lines of prior therapy. The other thing that's kind of exciting are bispecific antibodies. We talked about some of the kind of standard or more traditional antibodies, but what a bispecific does is the antibody identifies something that's already on the CLL cancer cells, and most of the ones I'm going to mention here go after CD20. And then they bring the immune cells or the T cells to kill the CLL cells. So it's another kind of way that we are activating the system. And again, there are several drugs I've listed here: epcoritamab, mosunetuzumab, glofitamab. They're approved for other types of lymphoma, not approved for CLL yet, but there's a lot of clinical trials ongoing. And so, that's kind of a whirlwind tour and kind of, a general overview of the reasons to start treatment, options for second, third line, and some of the new treatments to watch. And so with that, I will conclude my presentation.
Great. That was a fantastic presentation, and truly all three of you did a wonderful job with your presentations. We are now at the Q&A portion of the presentation, so if you have any questions, just go ahead and type them in the Q&A section there. I do know that we have people in already. So first one here, is there any encouraging news for those of us living with high-risk CLL? I'm currently in watch and wait, but will there be any good fixed duration options for us in the near future?
I would love to answer that question because I'm very personally invested in it. So right now at the current time with high-risk CLL, if you've been diagnosed within the last 18 months, there is actually a clinical trial looking at early treatment with venetoclax and obinutuzumab, which is the Evolve S1925 trial. And so if you have high-risk disease, and that's defined, I know Dr. Lamanna talked about the CLL IPI score. That means your score is 4 or higher, or maybe you have something called a complex karyotype. You might be a candidate to go on this and try to understand what the question we're asking is, can we improve survival by doing treatment early? And we don't know the answer to that question. And so going into that clinical trial, you have to feel comfortable that you're going to go through something called a randomization, which means 2/3 of people get the treatment, the venetoclax and obinutuzumab, and the other third of patients, they actually still do watch and wait until a time point when they meet criteria for treatment. And so this clinical trial is open all over the country, and so most likely there's a center near you. And so if that's something that might apply to you, I think that's something that's really exciting that's going on. currently, but maybe you don't fit into that. Maybe your risk score isn't quite high enough. That's great. And maybe it's been longer than a year and a half since diagnosis. And so, at this point, no early treatments are available, but there are so many clinical trials that are ongoing for frontline therapy. And what I really like is I've seen a real shift to having specific cohorts in the trial, meaning they specifically study people with high risk instead of just saying, well, here's everybody, and then let's separate out and see how the folks with high risk do. So a good example of that, Dr. Fakhri mentioned the Sequoia study. There's a specific arm on that study for people who have high risk disease. And so we're getting some really good data. And I think, the numbers keep getting better. And I think you have to be really cautious when you say high risk, because some of these risk scores were calculated a long time ago. And so some of the risk scores, like the CLL-IPI score, it's a lot more helpful now in predicting the time to first treatment, as opposed to like survival, how long you'll survive, because the treatments just keep getting better. And so I think there's a lot of hope for folks that have high risk disease, because the treatments really are showing great benefit in all different groups of patients.
I'm going to echo that. For sure. I think that if you're high risk, there's a lot to be hopeful for. And I agree with Deb. If you can, what would be great is to be on a clinical trial, only because it may give you some advantages about the treatments, but B, it also is great to study a more unique population of rare individuals who are in frontline considered higher risk, where we're trying to figure out better therapies for you all. So I would echo what Deb says.
All right, next question up is, this can really apply to any setting, but how to manage weight gain with BTK inhibitors?
That's challenging. I can take that. This is a challenging question. Some of the side effects of some of the drugs we have, it is sometimes more difficult. There's no doubt. I think, it depends on, the question is there's nothing that we can say, hey, off the cuff that we could give you, except I think what the conversation would be important to share is with your provider. If this weight gain is becoming unacceptably difficult, meaning, so is this something that can't be controlled through diet and exercise, particularly if you're doing really great on the agent? Now, I think that, one of the things that Deb had noted in her talk, although I don't, to be fair, Deb, if we were to look at this data, I don't know if we've ever talked about it with the concept of weight loss. Sometimes a side effect on one BTK inhibitor doesn't mean you'll have that side effect on another BTK inhibitor. And so there is a concept of switching. Again, I don't think we've looked at it. I'm not sure any of the patients on the studies we had looked at it in the concept of weight gain, but that might be an option. So let's say you're tolerating whichever BTK inhibitor you're on really well. So the disease is working great for the disease. And other than the weight gain, your doctor could potentially try another BTK inhibitor. So if you're on acalabrutinib, you go on Xanu, or vice versa, or, and see if that helps with the weight gain. Otherwise, I would keep track of, the things that it may have nothing to do with diet, but I would keep track of that as well and see if you can incorporate more of an exercise routine, but talk about the notion of whether or not it's a possibility of switching, and see if that helps with the weight gain that you currently have on the current BTK inhibitor.
Great. I think that was a super thorough answer. Next up is one that's pretty relevant for things that are happening in the news. But are there any circumstances in which a watch and wait stage 0 CLL patient where they could get the measles vaccine? They're in the category, we only had the weak version in the 1960s. So measles vaccine for CLL patients, is that a yes or a no?
I'll take that. That's a no. Measles is part of the MMR vaccine, and it's a live attenuated vaccine, and we advise against live attenuated vaccines in patients with CLL.
Yeah, the only one thing that I might add to that, because I've had so many patients ask me this recently, what may make you feel better is to actually have your doctor check your titer levels. And I've done this for patients,
Yes.
checking to see, because you might be surprised that vaccine might actually have worked really well, and you might actually be immune. And you can tell that by checking the IgG levels in your blood. And of course, you need to check your total IgG levels as well, because a lot of folks with CLL just generally have low IgG levels. And so, kind of interpret that with your doctor's help. But it's very likely you probably are still immune from the vaccine you got previously.
Right. And then this question, I'm going to generalize it just a little bit, but if an individual went ahead and did obinutuzumab as well as acalabrutinib, um, they responded pretty well, but they stopped because of immunoglobulin decrease. There, what sort of treatments could be an option for them going forward? So more of a second line, but after obinutuzumab, acalabrutinib, what options do they have like available to them at that point?
I'm happy to comment. I think that there's certainly you certainly can be retreated. It sounds like so. If you did really well, you certainly have the option of going back to the BTK inhibitor in the future, as Deb had presented in her conversation about being relapsed and need new treatment in the future, but you're off of therapy. So sometimes you can go back to the same drugs. I guess the question would also be, there's no doubt that many therapies, and I don't know if the person had other complications. So maybe they had also infectious complications because, I don't know that we necessarily would stop therapy due to decrease immunoglobulin levels because a lot of therapies can do that in the short term. But the question is, were there a lot of infections and things? And that was the concern. And so there's no doubt that that can happen and patients might abort therapy early due to, recurrent infectious complications and neutropenic due to the therapy. But certainly you have an option of going back to acalabrutinib. You certainly have an option of going to venetoclax and combinations thereof, as Deb had presented. So you have multiple options of going back to same or combination type strategies in the future, it sounds like, given how well that person did.
All right. And then we are getting a little short on time, so I'm going to go ahead and just say this is going to be our last question, and I think it's a pretty good one. But are there any lifestyle or nutritional behaviors that I can do to stop CLL progression? Um, this individual's heard a lot about different mushrooms and supplements. What are your thoughts behind those?
I'm great. I'm happy to answer this question. Would love to hear what the other folks have to say too. I think there are a lot of interesting clinical trials or kind of basically correlative studies, which basically means that investigators have taken blood cells out of CLL patients and tested them in the test tube, to see if there are any things that help to decrease the number of CLL cells. There was a nice clinical trial done by the Mayo group that looked at green tea extract that looked like it probably slowed down the production of white blood cells. However, this was very quickly reversed when patients stopped taking it. They also tested like a very high dose that pill is like the pill that they use is actually not even commercially available anymore. And it would be the equivalent of drinking about 22 cups of green tea a day. And so people, even this like kind of small change, it resulted in a lot of side effects, some nausea, diarrhea, things like that. And so I think in general, green tea is one potential to use, but I don't think it makes a huge difference in the overall scheme of CLL. Kind of similar results for curcumin or turmeric. And then, so I don't think it's mission critical that people take these supplements. I would not advise that people, go out and break their bank taking them because I don't think there's enough data to support it. But there's lots of other kind of interesting things, like, for example, exercise can it helps to decrease inflammatory markers and actually at least in the test tube, it reduces the production of red blood or of white blood cells, the cancer cells. Conversely, people who have really high levels of stress have been found to have a higher growth rate of the CLL cells. So we don't know that stress reduction actually changes that, but there's some data that stress maybe enforces. So stress reduction, exercise, I think are really important techniques to think about. And one of the kind of newer supplements that has been tested is vitamin D. And vitamin D, again, this hasn't been prospectively studied, but there are just some kind of correlations that lower vitamin D levels result in shorter time to progression on therapy. Again, this is a correlation. It doesn't mean it's a causation, but I'm generally supportive that if your vitamin D levels are low, those should be repleted. But I think a lot more study needs to be done. So I think, I think it's just general healthy lifestyle stuff, and, just be wary of people who are trying to make money on folks that have cancer, and just don't, I don't think there's anything that's worth spending your life savings on, but there's a lot of great things that you can do. I mean, exercise is free. So that's probably the best thing you can do.
I just want to add one thing to Deb's comment is, there's a lot of just lack of data. So I don't think that Deb, I, or others want to say that there may be some beneficial, there could be potentially beneficial effects of certain supplementation. I think we just don't have enough data. The second part of that is you should always, always, always make sure that you're supplying that information to your providers, because what we have found is that patients may be on lots of supplements that may interact with maybe some of their other medicines. It has nothing to do with their CLL, but it may have interactions with other medications that may increase or decrease the drug dose level of their other medicines that might be important for their heart, or maybe blood thinners or things like that. And so I think it's really important that your providers know if you're doing supplements, so they can make sure that there's no interactions that may hurt you or your organ function. And I agree with Deb. I think we need more clinical trials in these areas to prospectively evaluate things. What might be good in one disease may not be good in another disease. And we really need the studies in CLL to help guide us about whether or not some of these supplements are helpful.
Great. And then, and do just a quick piggyback off of that. Do you have any information about funding and grants for continued research? We've brought up a lot of clinical trials and research, and I think people might be unsure in the current landscape, but do you have any words of research will continue, or just things that might help put people at ease if they're curious?
Oh, absolutely. I mean, so for those of you, there's lots of ways to help CLL research continue to be funding, as specific as contributing to bigger places like Leukemia Lymphoma Society, Lymphoma Research Foundation, the CLL Society in particular, who also supplies grants to applicants for their ongoing research. And so there's lots of different ways that you all can contribute if you're so inclined. And I think we all who do clinical research and laboratory research would welcome, obviously, any of that to help aid in what we're doing for you all.
And then just to let people know, we do here at HealthTree also have our Cure Hub. And if you connect your medical records there, you can take part in surveys and studies. So that's not even a financial contribution, but that can be a way to help push research forward. So if you want to get actively involved, I think Cure Hub's a really good opportunity for you to do so there. But I think that's the end of our questions, and I know that we are a couple of minutes over, so thank you all again for your time today. That was a wonderful presentation by all of you, and we'll go ahead and wrap up.
Thank you.
Thanks, everybody.
All right, so I want to let everyone know this is pretty relevant to our topic today, but we do have a new CLL SLL therapy guide up on our website. So this is a really good way to help you navigate what's the right treatment for you. So this guide was developed by HealthTree in collaboration with patients, care partners, and specialists to ensure that it is relevant to you. So you can learn how standard CLL treatments work, what to expect regarding their effectiveness in treating CLL, how side effects are managed, financial support options, and many others. So I think it's a really good resource. Please feel free to check that out. And then we have a couple of other events in the month of April for our CLL community. First one I want to highlight is a podcast that I recorded with Dr. Joanna Rhodes, and this is what are BTK degraders. So we heard Dr. Stephens talk about BTK degraders a little bit, if that was a topic of interest to you. Highly recommend checking out this podcast. It's about 20 minutes or so long, and it is all focused on BTK degraders. And then on the 16th, we're going to be doing a webinar about BTK inhibitors and cardiotoxicity, what CLL patients should know. This will be with Dr. Carrie Rogers. And then on April 25th, we'll be doing a staying focused on care while managing associated costs in very uncertain times. So this will be more of a financial webinar for CLL patients specifically. I want to thank AbbVie one more time for sponsoring us. Truly, we would not be able to host these types of events without them. And finally, thank you to everyone for joining today. Thank you for our speakers for all hopping on and doing such a wonderful job. I've gone ahead and added my email to the slide here. Please don't hesitate to reach out to me if you have any questions about HealthTree, any of our programs, or even if you just want to chat, I'm always happy to do so. I appreciate you all, and I hope you have a great rest of your day. Hopefully I see you at another webinar soon.